Welcome and thank you for joining us for tonight's session, What Care Plans Look Like After July 2025 with Dr. Ashley Van Leeuwensten. Now, my name is Sydney and I'm from the PHN Education team. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For myself on the Central Coast, that is Dark Injun land, and I'd also like to pay respect to all elders past, present, and emerging. Now, a few things to let you know about this session. It is being recorded and will be available for you to view in our PHN Education Library in a few days' time, along with a copy of the PDF PowerPoint presentation slides. As attendees, your camera and microphone are automatically disabled. However, if you do have any questions, please pop these through in the question box, which you will find located in your control panel, and we'll go through these at the end of the session. An evaluation will also come to you directly after the session. Your feedback is extremely important to us as it enables us to provide future education. Now, it is my great pleasure. I will hand over to Dr. Ashley Van Leeuwensten.
Thanks, Sid. Hello, everyone. I'm Ash. And I am the owner and creator of Better Billing, which is an online-based MBS educator. And tonight I'm going to hopefully give you guys a little bit of clarity of what's going to be happening from the 1st of July around our care plans and what we can expect in the future. So please feel free to add in questions in the chat at any point. If there's questions that you come up with later, just be wary that we do have a 3-part series. So tonight is part 1, and by part 3, it will actually be an open Q&A question with myself and Dr. Michelle Redford. So you are very welcome to either accumulate these questions then or ask me as I go. I tend to leave most of the questions to the end of the night because quite often people will ask questions and I'm about to answer them in the next slide. So hopefully you find this somewhat useful. So let me just... So first slide is I'm Ash. So for those who may not know me, I am coastie born and bred. I grew up here my whole life and am practicing medicine here as well, which is extremely awesome. So firstly, I am a GP and I'm still a reg until 12 more weeks. And I work at Waratah Medical Services at Morisset, which is an awesome little practice. Well, not little, it's quite big. Then obviously I have Better Billing, which is my creation that I started after I'd sold a previous business and was looking to do something else in this space. Got really interested into the MBS and then decided I was going to focus on helping people improve their billing and do so quite well, which has been fantastic. I also work a little bit with the PHN on their Savvy initiative, which I'll chat with you a little bit about later as well. And my other job, which is very big and busy, is mum to my 10-month-old little girl, Remy, who decided to sit in the chair with me one day. But it is all a bag of fun, as many of us GPs do. We all have many hats. So these are a little bit about the learning objectives tonight. Hopefully they're helpful. If you'd like to have a look, you're very welcome to at other points of the slides. However, we're focusing all on the chronic condition management frameworks and what they all look like going forward from Tuesday. So a little shout out for Health Pathways. So the Health Pathways guys got in contact with me, and what they actually do is have a look at what we're talking about tonight and added it into Health Pathways, which is a really good resource. If you're a reg, I personally always use it, thinking, what do we need to do in terms of referral processes? And they've got 2 new pages, one about chronic condition management items and one about MyMedicare. So have a look afterwards if you wanted quicker access to information. So let's talk the numbers. So you'll hear me tonight talk about 965 and 967, and then you'll also hear me talk about 721, 723, 732. So just become a little bit familiar with this. So if anything, the item numbers that you need to know about is the new ones, and that is 965, which is the preparing the care plan, or what I'm going to interchangeably call management plan and a care plan, and then also the review item number, which is 967. And you see here what the fees are. So it's $156.55, and you can see here that it's exactly the same price for a review and for a face-to-face. And you can see here that there's replacement of those item numbers there on the right-hand side as well, which I'll go through with you as well. So let's talk about what's staying the same. So what's staying the same is that the reviews are still available every 3 months, which you're able to do. Plans can be prepared every 12 months. However, that's not really the intention of the process of the plan and review that they're recommending. We'll go through that as well. You still have your patients are able to access up to 5 allied health visits per year, up to 10 for Aboriginal and Torres Strait Islander patients. And the 8 group sessions for eligible diabetics are also still vacant. So this is not a really common referral process to be wary of. So have a look. It is very, very much vacant. And our allied health guys can actually review patients to decide if they'd actually respond well to having group therapies, particularly dietetics or exercise physiology. And that's one offer that they can have through the access of the chronic condition management plans. The reports from allied health are still required and recommended. However, they're not relevant for us for billing. So that's a good win for us. So why are they doing these changes? And the biggest reason why is, one, you'll see that there's serious reduction of paperwork, which is a win. Team care arrangements are gone, which is so good because they were just a paperwork nightmare. And the care planning process is simplified. It will be better, but there are some things to be wary of as well. It's meant to improve your access and coordination, and most importantly, it's about linking chronic disease item numbers with MyMedicare, and we'll touch a little bit about that too as well. So let's talk about what's actually being made and what changes are being made. So 721 and 723 and 732 will be gone. So from Tuesday, the 1st of July, they will be completely gone. They'll be replaced by the new GP Chronic Condition Management Plan, or the long acronym GP-CCMP, and referral forms, which were our previous TCAs. They're going to be replaced by letters. So they will be going down the pathway of traditional referral letters, which I'll show you a few templates and ideas of what they'll look like. The fees between the plans and the reviews are the exact same as well. And there's been an introduction of what we call a 2-year transition period, which is mostly relevant to allied health referral. And I'll have a look at that with you tonight as well, so that you can see it's quite important for you to know, especially for allied health guys and being able to access their previous care plan allied health referrals and what that means for them in the future. So other changes to be wary of, and I'm not going to go too deeply into this, but home medication reviews for another 2 years, so the 1st of July 2027, patients will need to have an active GP CCMP or one of the new management plans from the 1st of July 2027 to be able to access the home medication review item numbers, or 900. A good time to mention, if you guys have been using the COVID assessment item numbers, 93644, those will be ending in the 1st of July. Okay, so as of Tuesday, they will no longer work. And we have had the sneaky little introduction of a menopause health assessment item number, which is exciting for those who do a lot of menopause health. And that item number is 695, and that's actually going to be starting the 1st of July as well. So I won't delve into that too much, but when I make reference to item number 695 later tonight, you'll know what I'm talking about, and just something to think of in the future around your medication reviews and how you'd like them to look in the future is the need to have that new management plan as well. So as of 4:30 this afternoon, as I've been religiously checking MBS online for new item number updates for 965, 967 and 695, it is not there. Okay, so it's still not fully confirmed what is expected in the actual item numbers requirements from Medicare. Obviously, I'm going to be keeping that up to date. If you're interested and want to be kept up to date, I very much welcome you to access our templates and make a membership with our guys online. It's free. You don't need to do anything specific about it, but we will definitely be in contact when we hear those changes. So to be confirmed, a lot of this information has been provided by the information sheets provided by Medicare and the MBS online. However, when it comes to the specifics of what it will look like on Tuesday, it's a watch this space, which is cutting it fine, but unfortunately it's a bit of traditional Medicare for you. So people ask me most commonly, what do I do after the date of the 1st of July and what do I do now? So the most common patient scenarios is when you've got a patient with an existing care plan, so a new, one of the 721, 723s, and they're coming in for their 732. And what you've actually got here is before the 1st of July, you've got the ability to continue doing your reviews with 732 as per the normal guidelines. So continue to do your reviews up until the 1st of July. From Tuesday, the 1st of July, all patients who are here for a review are recommended to be transitioned to start with a new care plan or the 965 item number. So in this particular case, as I've mentioned to all of the guys at Waratah, we're kind of focusing a lot on making sure that patients are all having new 965s for the first 3 months, and we shouldn't be seeing a 967 at any point between now and in 3 months' time. So starting a new care plan for all patients coming for reviews from the 1st of July is what you need to do. So as expected, if someone's coming in for a new care plan or they're here to have their 721, 723 renewed again, and it's after the 1st of July, the patient will be accessing through 965. So let's look at the referral process and the difference between the referral process. So on the left is what we're currently doing, which is where you've got your care plan that's been created, you've got your team care arrangements, which you send off, plus co-consents, and you wait the signature before you bill the 723. However, you also would previously be needing, your two providers for a team care arrangement. So that might be your osteopath and your physio, exercise physiologist, your podiatrist, whatever that might be. And so that is completely different now. So in terms of the referral process, you have your care plan that's been created and you create a referral to the allied health preferred provider, so whether it's your physio, dietitian, and you bill 965. There's no waiting on care plan, and there's no waiting on signatures, there's no waiting on acceptance of their team care arrangement. There's none of that anymore. So you're essentially focusing on providing the care plan, referrals if required, and then you bill the 965. There are also no minimum providers required at this point. So it is for a GP's discretion to decide whether this patient would benefit from the management plan. And as a result, there's no need for access to a specialist, access to other allied health. It's really up to yourself. However, quite a lot of our patients who are going to benefit from these plans already have allied health or other specialists in place. So it's going to be a part of including them in there too. So the transition period. So your transition period here is where we're talking about before the 30th of June 2027 and after July 2027. So this is over 2 years. So essentially, Medicare has explained that they are allowing allied health sessions from your old 721, 723s to still remain valid. So if patients have those referrals and they're able to be used up until the 30th of June 2027. If you are having patients that are needing a new referral or transition, you're best off transitioning them to the new care plan item numbers 965. And then obviously after the 1st of July, anybody accessing their allied health sessions needs to have one of the new GP chronic condition management plans. So let's talk money and talking the financial difference. So the biggest thing here I've got on this screen is a few things. So you can see here at the bottom, you've got the 9.9%. And the reason I've written 9.9% is based off our statistics from last financial year. The average GP's billing of chronic disease management item numbers, particularly care plans, is only 9.9% of their billings. Okay. I mean, we can all kind of reflect and see where we might be at with that, whether we are somebody who does substantially more than 9.9%. Are we someone that probably doesn't even fit 9.9%? However, something to reflect on here is that 60% of Australians actually have a chronic condition and they're seeing their GPs, and we're finding that we're only billing 9.9% here. So if that's you, have a think about it. Get yourself, educated, look into different types of things around billing, and think about, should I be accessing these numbers? Because you should, and they're available. So let's talk in terms of financial difference. So the table here is really what the average sort of GP is billing in terms of their care plans each year and what you can expect. So you've got, one sort of care plan done at the start of the year or at one point in the year, and then a review might take place in 6, 7, 8 months. Unsure. There's normally no structured reviews that need to happen every 3 to 4 months, and it might be by accident that you pick up the review number. And so the biggest thing here that you'll see at the bottom is the big red writing. And this is where you kind of look at it being that average GP with the 9.9% of chronic disease. And you can see there you're billing sort of 2 care plans a day on average, and say you work 4 days per week, how much of a loss you'll see actually from the difference in the fees from this new management plan and our previous GPMPs is about $1,100 per week of billing. And that's a really substantial difference. And I really recommend between now and then that you actually calculate what you think you'll be missing. But hopefully tonight there's some things that I can explain to you about other ways to find that income, and being able to bill that ethically and professionally, and in a way that obviously benefits your patient as well. So hopefully you kind of have a look at this and think about it for yourself. There are practices that I've worked with in the past that are currently looking at sort of focusing on increasing their private billing rates because of this loss of fee. If that's your practice, absolutely appropriate and completely fair. But if you're looking to hold on your fees, or you're looking to keep bulk billing as a predominant product of your business, then start thinking about other item numbers, and that's what we'll talk about soon. So you can see here, if anyone's ever done any of my webinars before, you always see I mostly talk about patient journeys or chronic disease journeys for patients. And you see here on the left side is what my average patient will end up doing in a year. So you can see here that they've got their chronic disease item number where they've got their care plan that's done. And this might be the second or third time I've seen a patient, and they've become my regular patient, and I get their care plan sorted. Then I always have their reviews booked in. So every 3 to 4 months, anywhere between 3 to 4 months, I see them for their review. Then you can see here that there's also an added number of a 705. So in this case, I've got a patient who's over 70, and I'm ended up doing their over 75s, or their over 70s 75 health assessment. And in that case, that's done at the same time as the review with my nurse, etc. 10997 is another item number that I really love to talk about. I won't focus on too much, but hopefully I'll be able to add it into talk 2 a little bit more about finding ways to, one, make your nurses time that they're already doing be applicable for billing. And if you don't use this number enough already, really try to add it in. Then you've got another appointment where they're here for another review, and you can see there's a 900 there. So I've organised for the local pharmacist to do their medication review for somebody who may be applicable for that as well. And then you can see here appointment 4 might be one private 23 that I might end up seeing them for, might be doing their license review, whatever it might be. And I might get them to add in another activity with the nurse, so whether their Prolia is due, whether I'm getting them to check on how their Libre sensor's going and tracking their sugars, or trialing different other investigations, which you can see in appointment 5 that I might have added into her care plan, the importance of maybe looking at peripheral artery disease and thinking about having an ABI, which you can see in number 11610. So obviously not a lot of practices have an ABI machine, but if you do and you're someone who does, then you've got that ability to bill as such. And then you'll be able to see here on the right hand side is just the implementation of those new management plan numbers. So adding in the 965 and 967. Now the point of where your reviews are with 967 and seeing that you actually really shouldn't be billing a 965 more than once, because there's no financial difference for you. The 965 can be billed every year if you need to. However, if you're constantly seeing the patient regularly and you're doing a review, there would be no need to do a 965. And so you would constantly be reviewing and constantly updating their care plan with their goals, what they've been able to achieve, and new goals that arise. So this is a favorite slide of most people's, and this is the co-billing reminders. And these are a table of co-billing that you can do with care plans. So when I talk about general attendance and care plans, you cannot do a general attendance item number with a care plan. There is some exceptions to that rule, and those are acute and urgent issues. So say for instance, you've got a patient who has come in for their care plan, and then they mention at a minute 19 that they've had crushing chest pain all morning and they're feeling a bit sweaty. Then all of a sudden this is a little bit different. Or if you've got somebody who is really suffering with a UTI and they really can't wait until tomorrow or the next appointment that you've got available, then that's appropriate. But I really recommend documenting with it. Medicare specifically has mentioned in the release of the management plan item numbers that we're talking about today that it really reiterates that you cannot bill this with a general attendance item number. So if you are doing so because you feel that you can, do so very cautiously. Then you've got your mental health care plans and reviews. So those are assessment items within themselves and are part of the chronic disease bubble as such and can be billed at the same time as your 965, as can other health assessments that are time-based. So your 705, your 707. You've got your heart health assessment, which is your 699, and your new menopause health assessment, which is your 695. And those are able to be billed with your care plans as well, as is your 715. General attendance item numbers like 713, which is the mental health care consult, or the antenatal attendances, cannot be billed with your care plans as well. And the same rule applies as what I've discussed with the general attendance item number. Investigations are another great option. So ABIs, ECGs, spiros that need to happen as well. They're relevant for your patient. They can be billed on the same day. And if you're doing it via video, sexual health, telehealth item numbers are also ones that you can bill at the same time. They're a great item number. If you're doing a lot of video or a lot of telehealth, when I say telehealth, I mean video, and you're accessing your care plans that way, that's another really great add-on that may not be relevant to the care plan that you'd like to add on. And then, of course, you can use your 10997 or 10987 to be used if the nurse is conducting another activity that's relevant to the care plan or the goals of the care plan. So again, I will focus on this in hopefully a little bit more into it too, but be wary that you can do that as long as the activity is reflected. So let's talk MyMedicare. So MyMedicare, essentially, we're all across what MyMedicare is now, and we've kind of had this case with the creation of these new management item numbers that it's now become everybody's business. We really need to start paying attention to MyMedicare and really start pushing and converting your patients into this system. And it is because it's going to become a big hindrance for you if you're and for your rebates if you're not having that done successfully. So what are the MyMedicare implications here? So firstly, patients must receive their plan or review from their registered practice. So if patients are registered at another practice, then you aren't able to bill your 965 or your 967. What will happen is it will appear as an exception, is what we've been explained. There's no, if patients are not registered, they can claim to have that this person is their usual GP, then that GP can claim the item number. If at any point you find your patients have gone down the road or they've gone to another practice, and as part of that practice's signing up procedure, they've added in a MyMedicare form and got them to sign it, whether that's ethically or truthfully correct, that's a different question. And what you end up seeing is, oh no, they've registered elsewhere. So what you need to do is actually re-register your patient back into the practice for that billing to be successful. So it's really important to try and sort of keep on top of it, and hopefully there's a few different ideas that you can get from this talk afterwards as well about what you can do. So as I say, MyMedicare is everyone's business, and I mean everybody in practice. So admin, nursing, GPs, it is everybody's everyone's business. And there's a few different ways that you can focus on helping patients get registered with MyMedicare. Think about it for your practice. You guys know how it works, whether you feel like it's admin or nursing staff that's able to do it, GP staff that are able to do it, whatever you need to do. But everybody needs to sort of be on board and attempt to fill the gaps of missed MyMedicare registrations. So for administration or admin reception team, you can sort of start to see we have been doing a lot during check-in or helping patients register on the app if they're particularly more telephone savvy, or it's not as easy for them to be writing, or etc. Then also pre-checking your appointments. So this has been particularly helpful, being able to just register them and have their form ready to go for them. Quite often reception will give them a spiel, and I often recommend that if the patient feels a bit confused or they're not sure, to get them to bring it in the consult with me, and I'll explain what the process is and why we're doing this. Most people I find are pretty good so far. The other thing is nursing staff. So in our workflow, we're kind of focusing a little bit on having the MyMedicare registration checked prior to the creation of care plans and prior to the creation of health assessments. Even though, it's not required at this stage for your health assessments, it's really important that it gets done, and that's another opportunity for it. The others is obviously the GP themselves is during their consult. Oh, hey, you don't have that green tick above your name. Oh, you're not registered with MyMedicare. And you can either do that just opportunistically during the consult, or otherwise you can do it by reviewing your list for the day. If you have Cubico in your practice, it's a really easy way to find who is eligible for MyMedicare on your list of the day. You can print it out, provide it to reception, provide it for yourself, and so that you can see who you need to give those forms to during the day. It is tedious, it's difficult, and it's not the most enjoyable thing to have to do, but unfortunately it's becoming a part where we all need to start to really ensure that MyMedicare is a part of your practice and your patients are getting on board with it as well. So this is my little cycle of MyMedicare and opportunities here. So you can see here in reception in the left-hand corner, that's where I've popped in my MyMedicare little sticker, because there's opportunities to check on MyMedicare and how patients are being adapted into that, whether that's getting them to sign there, showing them the QR code of how to do it, getting them to do the Hot Doc app, Hot Doc questionnaire to fill out for MyMedicare, however you're wanting to do it. Then where they might be here and they're going to see the nursing staff, and there what you'll see with the little icon, I've got the plan and the referral letter. So that is a patient who's coming in getting their care plan done. And you can see here there's a lot of other opportunities that could be happening at the same time. Is your nurse able to do a 715 at the same time? Is the patient applicable for a 705 or a 707? Are we able to do spirometry? Should we be doing an ABI on this patient? Do we have the equipment? Is it a part of the process that we want to be doing? The other options is your 699, so your heart health assessment. Personally, I love doing them with care plans, because otherwise they can be a little bit of a, how would I say, it's not financially the most viable option, but adding it in with your care plans makes it so. And then excitingly, we've got 695 as well with the menopause health assessment, and then looking at as there's other opportunities of nursing staff to be able to do follow-up access activities with their patients with 10997 or 10987. And then you can see here the patient's sort of seeing the GP, and you can see here that we're talking about what the appointment is, what we're actually needing to do, reviewing the plan, making sure it's fitting the criteria, you're happy with the goal creation, you're happy with the plan, and you're happy with everyone who's involved. And then also the possibility that the GP themselves can also complete that health assessment. So you can complete 715s yourself, or doing the heart health assessment during that time of that appointment if it becomes a 20-minute appointment, or the menopause health assessment themselves. And then importantly as well is when the patients go back out to reception, is looking for those future appointments and future billing opportunities. And so I'll show you an example of it here. So you can see here I've said Marnie is a 44-year-old patient. She identifies as Aboriginal, and she is hypertensive and she has type 2 diabetes. And you can see here she comes into reception in the top left corner, and she ends up seeing the nurse today. And what we're doing with the nurse today is the care plan with the referrals to allied health. So the care plan is completed with your nursing staff, and she is somebody who fits the criteria for an ABI. And our practice has an ABI machine, so we get our ABI done at that same time. And you can see that her levels are looking really good. There's no real risk of peripheral arterial disease, and we can forward on to the doctor for review during that time. Then they see me at this point of the appointment, and we focus a lot on lipids and hypertension control, and talking all about her cardiac risk factors and talking about her CV risk percentage. And you can see here that what we've done is been able to fulfill both the care plan requirement with nursing assistance and 699, which is your heart health assessment. And then here, what you'll be able to see in this part here is looking at future opportunities. So I can see here that, okay, your influenza vaccination hasn't been done. You're someone I wanted to find or get that done. So I'm going to get the nurse to do that at the appointment next week in a 10997. Then I've booked their review in 3 months. And then you'll be able to see that then 715 is due in 6 months. So you've got all these other opportunities here in the next few appointments where you're able to access more further chronic disease item numbers, health assessments that can be co-billed together. So as you can see, you've got that 967 done in 3 months, and it is absolutely applicable that you could be doing the second review with the 715 in 6 months' time, because that would be 3 months apart. So spacing your appointments, making sure that you don't sort of underhit it a little bit where you're a few days early, and getting that flow of chronic disease and co-billing opportunities all in that process, and continuing to do that with each time. So how do I do my plans? What's the option? What can I do? So for a lot of us, we have BP. So the BP has that built-in care plan feature, which you're very welcome to be able to use. You can create templates on it yourself. You can do whatever you particularly like. A lot of our nursing staff still go down that pathway, and I'm happy for that to continue. However, I am a big lover of Lyrebird. I'm not sponsored by Lyrebird. I pay my subscription, but I love the product. So in this particular case, what you'll be able to see here is a fake patient that I've been able to create. These templates will be available towards the end of the talk, and I really encourage you to scan the QR code, go on and grab the free templates, because they're free for anybody. You don't have to be a paid subscriber to access these. And these are care plans that I've created through Lyrebird. So I've been able to create templates that fit the criteria of what I'm wanting on my care plans. And you can see here on the left-hand side is my appointment that I've had with one of my patients. And we're talking about pelvic flare, endometriosis, talking about Marina that needs to be due, and we're talking about her issues with having time off work, and she really wants to reduce that by 50%. That's her goal. And what you'll be able to see here is in Letter Writer, I've been able to create the care plan with the exact SMART goals, how I want it, in all of the fitting all of the criteria that I'm after. If you have a look at that template, you'll be able to scroll down and see that it has a really great spot for every listing all of the allied health or other non-GP specialists that I've mentioned during those appointments, and adds that in very easily into your software by just copying and pasting and popping it into Letter Writer. So if anything, you're thinking about AI, you've got Lyrebird, you don't really know about how much it will be useful, have a look, try my template and see how you go. So this is another option, is the referral letter, and what the referral letter looks like. So the referral letter is really, really simple. And so what you'll be able to see here is just a fake patient that we've created. It's literally just got the allied healthcare plan, number of sessions that they're allocated, find the referral details below. And what you'll be able to see here is I copy and paste the care plan into the letter, which is able to be previewed in the BP section of the EPC or the care plan, or if you've created it through Lyrebird, copy and paste it through there from Lyrebird, and literally have it ready to go and emailed very quickly. It makes the workflow very, very simple and very easy. Again, if you prefer to use this template as well for your allied health referrals, completely free, downloadable, with the QR code that will come up at the end. So practice preparation checklist, and this is normally what I sort of recommend having a look at moving forward. I mean, I know it is Tuesday and it's coming, but there's lots of things that you can do. So one thing is auditing your patient list for active 721, 723s, and 732 plans. When are they due for the review? Should they be booked in for review? Do you have them booked in? And if you haven't, access them and contact them, trying to say, oh, we're trying to book in your care plan review. You had one 4 months ago, it's due, etc. Update your templates or referral processes. So add in your templates into BP. Don't do it on Tuesday morning. Try and do it a little bit earlier, and make sure they're all added to your favorite sidebar for quick access as well. And training your staff. So if you have time between now and then, let them know about what these item numbers are. Share them with this recording if you'd prefer. That's fine as well. Just explain what they can expect for the changes in Medicare. So everybody, admin, nursing staff, GPs, all need to be able to know what they look like in the future, and what will be different come next week. Also communicating with your patients really clearly. So I have had a few patients say to me, oh, the care plans are going, aren't they? And no, that's not really the case. They're changing. Your sessions will still be valuable. You'll absolutely be able to have them, and explaining if you need to about how they'll move to the new model during those reviews, particularly those who are very cautious about their 5 visits that they like to make sure that they get great use out of. So one thing I wanted to mention tonight is about better billing and our work that we have with Savvy, or the Sustainability and Viability Insight or Innovative Group. And what you can sort of see here is Better Billing actually has a partnership with the PHN where we're offering grants to help GPs particularly improve their billing. So at the moment, we have, from memory, I think there was about 100 subscriptions that were given, very heavily discounted for people within our PHN. So there is both coaching, which is more one-on-one small group coaching, as well as the courses. And then there's also course access, which is my online on-demand courses that you can start straight away. We are fully booked already in the coaching group. However, we still have about 50 to 60 available subscriptions for the courses. So if you're particularly keen to try, if you've got GPs in your practice that you're like, yes, definitely, the discount is very substantial. So from memory, instead of it being $330 for the 6 months access, I believe the PHN has reduced it down to $63 per GP. So $63 for full 6 month access of courses. You can see I update courses quite regularly. Obviously at the moment it's a very busy time, so more and more courses are being added about new health assessments and new changes, and these grants are available. So please have a look, send them to your practice, send them to your GPs, let them know about it, and we've been having some good feedback so far about it. So please, it's there. It's seriously reduced in price, and I hope, for those of you who are interested, it would be particularly useful. Then just to mention here towards the end of this, we're talking a little bit about health pathways. So they just wanted me to mention you guys all now have to have your own logins to be able to access health pathways. Make sure you register. It's easy. I got my access really quickly, so it's quite simple. And the other thing they wanted to be wary is that their shared login details that we've all probably used for years is now also ceasing, and you'll need to get your personal access there done as well. And yes. So if you are interested in talking more about practice-specific support, etc., so in terms of better billing, we've got our courses that are online ready to go. Template access is normally complimentary for most of our course subscriptions. So if you still love to write and type your notes, I have over 115 templates from different presentations that I have used and created all over the last couple of years. If you're very welcome to, there are the coaching options as well, and a bit of practice solutions. So for those who are really interested in really trying to, whether their practice is in a little bit of strife and they're really wanting help around business solutions and practice solutions, that is something I do, which is really enjoyable and fun, and I love to do. And you can always just have a chat and ask about what services are in terms of option. So this is the last slide, and this is the QR code for if you are wanting templates, my MBS cheat sheet and info summary sheet. Obviously, the MBS cheat sheet is going to be very different come Tuesday. Ours will be launched hopefully Wednesday to Thursday so that we can update our pricing depending, or to update the prices on the MBS sheet with indexation. So please give us time, but it will be there. Any templates that I mention in any of my webinars or create are all available here on that free resource hub, so go right ahead. On the right-hand side is a infographic that I made around the first time that we found out about what the care plans, our care management plans look like. So this is a really good one to print off, give to your nursing staff, give to your admin staff, so they can just see the specifics that they need to know about. So what are the item numbers? What are the fees? What are they going to be replacing? What's the difference with allied health? Why do we need to worry about MyMedicare in this stage, and other little things that might be a little bit more relevant in a more concise document if they don't want to listen to me talk the whole time, or don't want to do their own research. It's an option for you there as well. So what I will do at this stage is I'm going to drop that question box down. So if there's anything specific that you wanted to know, please pop it in. So I'm going to start from the start. Do we need to specify how many visits are required in the allied health relator? Yes, you do. And so what you'll be able to see in my template is I've just literally put little X's there where our nursing staff can say 3, 4, 5, etc. However many you need to have in is absolutely fine. Okay, do we need to wait 12 months from the last 721 to bill the new 965, e.g. eligible for 732s, as it's been 3 months since 721? Do we do 965 instead of 732? That's absolutely right. That was a question from Jessica. You're absolutely right. If you have patients that are eligible for the 732, it's recommended that you do the 965 instead of the 732. So you start everybody in the first 3 months on this new management plan. Okay. That. In terms of podiatry, that's a good question. As a podiatrist with an ABI machine, will we be able to bill for this separately, or is this only for GPs? That's a great question. Let me pop your details down, Nanette, and I will send you an email specifically, because it is in an area that's actually not specific to who can or can't do it. So the item number to look up in particular, which I'll write back into your message, is item number 11610, and have a bit of a look, but you may also be able to bill this as well. Okay. Okay, allied health. Question from Emma. Allied health, how do we know when a new referral is needed if no visits are listed? As it says in the fact sheet, they don't need to be listed, yes. Will there be a visible difference for regular and Aboriginal Torres Strait Islander referrals? If the GPs don't have to put a count on the referral, how will we be able to track how many visits a patient should have? Should we assume it's only for one visit if no numbers of visits are listed? Yep, okay, a lot there. So I suppose the biggest thing is, how will we know when a new referral is needed? And this is one thing that often comes up in contention. So one of the things that you can do is, for GPs, our patients often will be quite educated in this, and they'll say, oh, I'm due, or I'm able to have them. In terms of being able to track how many sessions, there's a few different options. There's one, might be their My Health record, if you're able to access it and they've given you permission to it to be able to see so. That might be one. There will be a visible difference for regular and Aboriginal and Torres Strait Islander patients. So for me, specifically, my referral will say this patient identifies as Aboriginal, and they'll be able to see which specific sessions, a number of sessions are out of 10 rather out of 5. So that's one way as well. If the GPs don't put a count on the referral, how will we be able to track how many visits a patient should have? That is really difficult, and I mean, it's really hard because I'm sure not a lot of them will. I would, try to really either respond back and say how many visits do they want, and really try to educate everybody in this space to say, we've got to list how many are there. But yes, a really good point. Oh gosh, we're getting a heap. Okay, hang on. Okay, so Jillian asks about outstanding 723s that are awaiting to be billed. Is there a time frame to have them finalised by? Okay, so from what my understanding is, your 723s, there's two things that I'm going to mention here. One is I really recommend that you actually have a look at what the MBS is saying about 723s. In October, they changed their information on MBS online, saying that you no longer needed to hold, or the sentence that said you needed to await signature or confirmation from allied health members around confirming their acceptance to be in the team to bill the 723 has been removed. So depending on how comfortable you are, what you plan on doing, 723s are able to be billed without those signatures returning. And personally, I have been processing it that way because the item number is about to end. However, if you are persistent and you would like to continue to follow up what the rules were previously and you're waiting for your signatures, then you have up to 12 months. Okay. So someone asked, Nat has asked, 721 on the 30th of June, do we have to wait 3 months to do a 965? Yes, you do. Yep, you do. Okay. Okay. Oh, I'm getting a bit smashed here, Sid. Sorry.
Sorry, you're making me laugh. Okay, we'll go into Kristen's, which I think was the. I'm watching him too. I'm like, wow, this is hammering. She's doing a great job. All right, I think Kristen asked the
Okay.
same exact question. So there needs to be a 3 month
Okay.
gap between the past 721, 732, and billing a 965. Correct?
Yep. Yep. Sue's got patients need referrals for 2 different providers in podiatry and physio. Who will stop one provider using all 5? These are great questions. These are really good questions. That will be something that we'll all sort of face and look at in the future. I'm not particularly sure. I suppose all you can do is make sure that you have specified on your referral form how many sessions you're wanting each provider to use, and make it really clear, which I'm hoping will be the case.
Go into Genevieve's again, and some of these, if they are repeated, just say, yep, we've done it. We'll move on to the next. After July
Yep.
1st, and we do a 965 for those with pre-existing plans, do we get new/fresh set of 5 sessions?
No, so that still will remain. So your 5 sessions that occur in the calendar year are still the same. So no matter what, though that will still that won't just refresh and they'll get a whole bunch of new 5. No.
Perfect. Will the 10997 item number continue? From what I've read and heard, I thought it was going.
No, that will continue. That is continuing at this stage, from my understanding. That is not on any radar for review at this stage. No.
With a heart health check 699, doesn't there have to be a 12-month gap between that and a health assessment? Also, will that include the new menopause health assessment?
Yeah. Okay. Great question. So 699, yes, you do need to. 699 is a health assessment that I only will sort of give to patients who don't fit the criteria for a time-based assessment. So 705, 707. Patients who identify as Aboriginal are able to have both. Okay. So they are able to have their 715 with a 699, and that is appropriate and fine to be done. But in terms of how you need to be 12 months apart from each 699, that is absolutely correct. But if you have somebody who is also a little bit who fits that criteria of at risk of diabetes and they can have a 705, you're better off going down that pathway before giving them a 699, because that will actually stop them accessing the higher rebate of the 705 if you bill a 699, say 4 or 5 months prior.
Continuing on from that one, please tell us more about the 10997. Can we bill this when nurses do the 965? Thank you.
Yes, okay. One, I come to talk to, it's going to be in there because it's been a common question. So 10997, I will definitely talk about in talk 2. But yes, activities that happen inside of a 965, if it's relevant, I mean, in a 695 or the menopause assessment, if it's relevant and they're claimable and relevant to your chronic disease management plan, then yes, you can.
Also, it seems patients will need to be keeping track of their 5 visits as no numbers are required. This is a minefield Allied Health will have to build privately, so not stuck.
Yeah, absolutely. And I feel for you guys, and I hope that they come out with more information for you. From a GP point of view, it seems simpler, but for you guys, it's really difficult to manage. So I understand, but I don't have any other information on that from an allied health point of view at this stage.
Is the GCCMP still be calendar year if they have used all their Allied Health services on review?
Yep. So yep, we've answered that one. Yep.
Next one. Also, with a 715, can you bill a 699 heart health check if you can do at the same time?
Yep. Yep. I think
Next
I
one.
covered that with my 699 check.
Yep.
Yep.
PT needs referrals for 2 different providers in podiatry and physio. Who will stop
I
one
think I've
provider
spoke.
using all 5?
Yep. I've chatted with that one before. I think. Yep.
Okay, next one. Did you mention COVID vaccine suitability assessment numbers 93644 are finishing? Can we then charge a private nursing fee? I bet pharmacies are still getting paid to give them if this is so.
Yeah, so 93644 is completely gone from the 1st of July. And I mean, it's up to you how you wish to do this, but our numbers are gone.
Another request to be emailed about podiatry and 11610, please, which is great. Thanks for asking that because we do have your email with the questions, so we will get that to you. I can't access your templates.
Oh no,
Re-
those the though okay, so that template there specifically, you're looking at the templates for the 100 like documentation templates. The one you need to look at is the resource hub, which is this QR code there. Or if you go to my website and click down more, you'll see resource hub, and they are completely free. You just need to log in with either a Google or a Facebook or your own email, and you'll be able to get access to them straight away.
I think we've done this one again, but sorry, we'll just go through it again. Can you bill a 10997 with 965 or only
Mm.
review 967 only?
Yeah, so this is really quite dependent, and I would say the short answer for this is no. So the reason why, when you've got 965, you're creating the care plan for the first time, and as such, you can't really be completing tasks that are relevant for the management plan in the first appointment. Theoretically, you could, if there is a task that we say influenza vaccination, Prevnar vaccination is important to get done in 965, then absolutely we could say that yes, you have completed a 10997 task. However, it is something that just to be wary of, but it cannot be used for the creation of the care plan or the management plan or the information gathering. It cannot be used for that.
Templates via the QR code are not free. There's an annual charge when I've used the QR code just now. Is that correct?
No, so that was the one I was mentioning about the documentation. They've just got to click the resource hub, which is the free one.
Right. Thank you for clarifying that again. You indicated ATSI can access 10 EPCF. Sorry. Doesn't that mean 5
Yep.
with care plan and then 5 with 715 to make it 10 in total?
So yes, so in this case, what you're actually able to do is you can do that is correct. Joe is correct with this one. So in 10 in total is through the 715 and the or not EPC, yep, GP chronic condition management plan. Yep,
So if they present for care planning, either plan or review and 3 months has passed, we just do a 965.
that's exactly right.
I think we did it. We got through them all.
We did
Whew.
it.
Any more? We still have a few more minutes on the clock. Send them through. But yeah, we do have. So like Ash said, we have 2 more sessions coming up. Our next one is on the the 24th of July. If you have not registered for that yet, please log into our website. You'll find it in the education calendar. And then the following one from that is about a month after that with Michelle Redford, like you said. But besides that, we will love and leave you. This recording will be available again as discussed. PDF of the documents will also be up with that recording, so you should be able to access that. And we have had another new question. Thank you. No, thank you guys for all
Oh,
coming. And
oh,
Ash,
thank you.
huge thank you to you.
Yes,
You are a wealth of knowledge, and it's very
thanks,
impressive
guys.
just being on the receiving and listening.
Okay, thank you.
Perfect. Well, I will end that for everyone. And please remember, fill out our evaluation, and we will see you in a month's time. Have a good night.
Thanks. Bye.